Yes, yes.
Yeah.
I was there. My family's stepmother recently passed away from Lewy body dementia, and it was tremendously spot on. I will tell you that. No, it was very of how all of this was. That's kind of cool. Okay.
I'll go ahead and introduce Michelle. Hey, good afternoon, everyone. My name is Al Ortega, and with Joseph Lennon, I'm co-director of the Villanova Initiative for Climate Justice and Sustainability. Thank you for coming. We're the host, along with the Valley Library, for this lunchtime series. So our speaker today is Dr. Michelle Kelly from the School of Nursing. Let me say a few words about Michelle. She is an associate professor and co-director of the Mid-Atlantic Center for Children's Health and the Environment, Region 3, which is Pediatric Environmental Health at Villanova. She's a fellow of the American Academy of Nursing, which is a prestigious honor in the American Association of Nurse Practitioners, and her research centers on health outcomes of people born prematurely, particularly linking between preterm birth and future health, which is complicated by environmental exposures, poverty, and toxic stress. We're delighted to have you, Dr. Kelly. Thank you.
Thank you for having me. So all good lectures start with objectives and disclosures, and I unfortunately come with a warning label as well. So the objectives for today is that I hope you all will learn something about prematurity. I do not have any financial disclosures, but the warning is that prematurity really is more than meets the eye. And when I give a version of this talk to physicians and clinicians, I tell them that my warning label is that I'm going to force them to think differently about prematurity. And every good lecture starts with making sure we all have the same terminology, that we understand what language we're using, and a little bit of history. So on the slide here, you see the categorical definitions of prematurity. So preterm birth is, by definition, birth before 37 weeks of gestation. The other categories: extremely preterm, very preterm, moderately preterm, and late preterm. That is the majority of kids that are born early are born between 32 and 36 weeks of gestation. So if you were to imagine a preterm, the majority of preterms, they look like the baby on the bottom, which is a 35-weeker, 7 pounds, as opposed to the baby on the top, which is a 25-weeker, or 26-weeker rather, who was born weighing less than a pound. So she is considered small for gestational age. So she is even smaller than she should have been born based on those 26 weeks. That's the image that most of us have when we think about a preterm baby. We also have birth weight categories for preterm birth: low birth weight, very low birth weight, extremely low birth weight. Survival rates for people born preterm: less than 24 weeks of gestation has about 40% survival at this stage. The edge of viability is about 22 weeks. Although 20 years ago, when I was actively resuscitating babies in a NICU, I would have told you the edge of viability was 23 to 24 weeks. And 20 years before that, they would have told you that the edge of viability was 28 weeks. Lots of reasons why premature babies don't survive, and we're going to go over a little bit of that. The other piece of prematurity is that babies have always been born early. So we have to start with a little bit of history. We have to start with a little bit of history. So in the 1870s, 230 of every 1,000 births died. The major causes of death for infants at that time were hypothermia, respiratory distress, infection, and weight loss. Newsflash, they're still the important things to worry about. We haven't changed that. Babies still need the same thing. They need to stay warm. They need to, is it the cord, do you think?
I don't know. Let me come check.
So they need to stay warm. They need to grow. They need to stay out of infection-free. The fascinating thing about the history of neonatology is that it's really evolved in the last few generations. So in the 1920s, formula or a substitute for breast milk was Caro syrup, evaporated milk, and a little bit of rum. Caro syrup gave calories, rum made the baby sleep, and evaporated milk was what you had, right? In the 1930s and 1940s, we had World's Fair exhibits that were incubator rooms, and Martin Cooney made a killing, charging people admission to gawk at babies in isolates, okay, in clear glass boxes, okay. At the same time, Boston lying in children was featured in a Life magazine article, and the heading was, Boston's lying in hospital incubator rooms save premature babies' lives. Okay, this was groundbreaking, life-shattering work that they were doing, and what they were doing was keeping babies warm and fed, and as much as possible infection-free. Their activities for how to keep them infectious-free meant that even though Cooney was, the original pay-per-view guy, Boston Lying in Hospital allowed parents to view from the window for 1 hour a day, and they were never allowed inside the unit. Fast forward to the 1960s, Patrick Kennedy was born at about 34 weeks of gestation. He lived exactly 2 days. He was 34 weeks gestation today has a survival rate that is the same as a term infant. Okay? What he had was respiratory distress syndrome, surfactant deficiency, but the accomplishment of that 2-day life was that it changed the way it changed the science of neonatology, because suddenly there was a interest and a focus on how to take care of infants born early. This ventilator here is a baby bird. It was one of the first ventilators. It was being developed at the University of Toronto by a woman I had the very good fortune of actually working with, Maria Delbora Papadopoulos. And it was available in Toronto, not here in the US. So hindsight might say that Patrick probably would not have survived the trip to Toronto, and getting the ventilator here from Toronto probably wasn't efficient either. Or you could say that it was political suicide to transfer the sitting president's son to a hospital in Toronto. However, by the mid-1980s, we had appropriate ventilators. We had tubing and diagnostic catheters that were of appropriate size for infants. And healthcare really changed in the 1980s and early 90s for people born early. And truly, that is a testament to his young life. Now, fast forward to the 1990s, we have had 3 decades of preterm birth rates being solidly at 10%. We had a small blip in 2006, 2007. But basically, what that preterm birth rate and today's survival rates mean is that every doctor, every clinician, every nurse, every teacher is teaching someone who was born early and they don't know it, or is caring for a patient who was born early and they don't know it. Okay. Health risks for people that are born early are, and this is not only my research, this is comes from an executive summary in 2016 from the NIH. where they identified long-term health risks of people born early. Okay, reduced pulmonary function, hypertension, diabetes, increased risk of mental and behavioral conditions, and learning differences. They are the absolute risk factors of preterm birth. So this isn't one study suggests. This is a culmination of the science. And these 4 categories have been reinforced in the literature following the 2016 executive summary. Some of my own work, as well as some really amazing researchers and epidemiologists have looked at this over time. It's also important to recognize that when we talk about preterm birth, we're not talking about, size matters. So gestational age and size do matter. The smaller you are, the earlier you're born, the increased risk you have. But it's not to suggest that the kids that were born between 32 and 36 weeks are absent of risk, because they do still have risk. Kajante in 2019 put out a study looking at late preterm, so that's the kids that are 34, 35, 36 weeks of gestation, and early term, so 37 through 38 weekers as well, and found very similar outcomes. Little less odds ratio, but very similar outcomes. So it's a very multifactorial disease, and that's why environment matters quite so much as it does. So I'm a big framework girl. I like frameworks. I'm not really good at theories, but I like frameworks and models because I'm a very visual person. So this helps me think. And when we talk about environmental exposure, we talk about preterm birth, you cannot separate the environment from the outcome. And what we're talking about is both the proximal environment, so those day-to-day exposures, the home life, the interaction with the caregivers, right? So that's the proximal environment, but also the distal environment, the air pollution in the air, the substances and potentially toxic substances that they're exposed to in their social environment. So we need to always think about both pieces and how they affect child health in general, but preterm child health more specifically. Preterm delivery itself is a sequela of the environmental risks. We'll go through a couple of slides where we'll talk about what environmental risks contribute to the preterm birth rates. And then once a child is born preterm, they have an increased susceptibility or an increased vulnerability to those environmental exposures. So environmental exposures that contribute to preterm birth or preterm delivery, tobacco exposure is still one of the most modifiable, in my opinion, exposures. We know that prenatal tobacco exposure is linked to preterm birth, fetal demise, and growth restriction. Also linked to impaired lung function and structural brain anomalies. And cadmium, which is a byproduct of tobacco, it's found in tobacco smoke, is actually linked to preeclampsia, which is a hypertensive and kidney disorder that significantly contributes to preterm birth. In 2016, a study looked at 4 million singleton preterm births to try and see if they could come across a biologic explanation. What they found was preeclampsia and prior preterm birth explained the highest individual indicators. Okay? However, 2/3 of preterm births occur with no biologic explanation. So, job security for me. There will always be preterms because we don't know what's causing the majority of it. The boxes at the top are numbers from the March of Dimes. And the March of Dimes suggests that 40% of birthing families are exposed to extreme heat. 73% of birthing families are exposed to poor air quality. Wildfires being, and other respiratory toxins being a significant contributor. not just from a stress on the childbearing person, but also the childbearing family itself. So a family who is living through a wildfire or some other natural disaster experiences PTSD, experiences stressors related to housing security and an impaired ability to provide a safe and nurturing environment. All of that contributes. So they're not only having the exposure of that air pollution, but also what it's doing to their family unit. Lead. So myself, Ruth McDermott Levy, are the co-directors of the Mid-Atlantic Center for Children's Health and the Environment. One of the majority, number of our calls, and Susan Rubenstein is here as well. She's our project manager. We field lead questions weekly, right? Lead is a significant risk factor that's associated with preterm birth. And it's typically early first trimester exposure. So ACOG guidelines right now support a risk-based screening for lead exposure. I would argue that a lead test is not that expensive, and we should be doing it on every person who is considering having a family, because we could catch a lot of this early first trimester exposure. Lead, as a rule, there is no safe level of lead. We have reduced the target number to 3.5 from 5, but truly we are seeing earlier deliveries with women who have a lead level of 3.5, 3.8. So it is a universal thing. It affects child health. It's going to affect neurodevelopmental outcomes in the child itself, and contribute to preterm birth. I love this graphic. This came from WIDA et al. It's a 2024 visual abstract about how climate change degrades child health. It was formulated from a systematic review and meta-analysis. This graphic is particular to child health, not preterm child health, but you'll see heat extremes lead to preterm birth. Cold extremes lead to preterm birth. Poor air quality leads to preterm birth, right? So that component of being born early is a feature of the environment itself, and also places children at greater risk for health outcomes. Because this is really a talk about preterm kids, right? What makes preterm kids so vulnerable? I'm going to focus just on lungs and brains. There's a lot of other body systems, but lungs and brains are the ones we're going to talk about. Lungs develop through gestation. They grow, the air sacs themselves grow as the fetus grows. So when fetal development is interrupted by early delivery, you're born with what you got, right? So you have small, underdeveloped alveoli at birth because you were born early. Surfactant, which is something that I tell the students looks like Dawn dishwashing liquid. It's a soapy kind of substance that overcomes surface tension and helps keep lungs inflated. That does not occur naturally in the body until about 34 weeks of gestation. We can give you some steroids to boost that and make it happen a little bit earlier, but not a lot earlier. So when you have an inability to keep those lungs inflated, the treatment for keeping them inflated causes damage to those fragile air sacs. Okay, so we get damage to the lung tissues that can result in a respiratory condition called bronchopulmonary dysplasia, and that is long-term preemie lung disease. It is a stiffening and thickening of the alveoli that makes it very difficult to ventilate them. Those are the kids that you see who go home on oxygen, or go home on a ventilator, or perhaps go home with a trach that is structural and they can be active and not attached to things during the day, but at night they're connected to oxygen, supplemental oxygen, or perhaps they are connected to supplemental oxygen when they have a cold. Wrinkles are good in brains. We want wrinkles, okay? So we want this sort of spongy looking here with lots of folds. This is the brain of a 25-weeker. Not a whole lot of folds yet, okay? Because they happen over time. And so when we have lung development that is, or brain development that is interrupted by an early delivery, that brain itself is more susceptible to damage, okay? Brains grow over through childhood, lungs grow through childhood. So it's not a one and done. Kidneys, unfortunately, are a one and done. You're born with all the nephrons you're ever going to get, okay? So you were born early and you have less nephrons, you're not going to grow anymore. Lungs and brains do keep growing, so that's a great thing. But we have, we're growing those brains and lungs in a less than ideal environment. We're growing them in extra utero, so in an environment that exposes them to lots of stressors. So the effects of preterm birth on child health: lead, particulate matter, nitrogen dioxide, sorry, sometimes my lips don't work, ozone, right? They all affect respiratory health. Lead affects neurodevelopmental health, and all of that affects the health of the child. Volatile organic compounds, polycyclic aromatic carbons that come from traffic sources, VOCs come from paints and some other furnitures and combustion engines. All of these exist within the environment. So you put a preterm kid in the environments that have these toxins, we are going to impair that already vulnerable child. And this is the slide that freaks me out, okay? Because we talk about prenatal life, right? We talk about respiratory distress and asthma and BPD that happens in kids that are born early. You add smoking and air pollution to that, and you get COPD. That's chronic obstructive pulmonary disease. That is old person lung disease, right? And I was at a conference this past, over spring break. I messed with the minds of a lot of physicians and neonatologists talking about this, talking about long-term outcomes, because what we're seeing is COPD in 30-year-olds. 30-year-olds. That's not that far from a lot of you, right? They have, and we are seeing it in preterm born people who didn't have BPD, but who perhaps had respiratory disease that was complicated by a couple of bad colds or a couple of bad respiratory conditions that got them readmitted to the hospital during their childhood. There's a study by Smith and colleagues that suggests that one respiratory admission during childhood increases the risk of early COPD in a preterm person, not in a not in a person with normal lungs, but in a person born preterm. Even one respiratory admission during childhood can lead to that. That is shocking, okay? That changes medicine and healthcare. We need to change how we talk to people who have children that are born early about risk. And in case anybody's starting to get totally freaked out or worried about, well, oh my God, my cousin was born early or this or that, please remember that everything I'm talking about is risk. And that's what makes preterm outcome research so difficult, is because gestational age and birth weight are not enough to predict outcomes, okay? We add all of the environmental risks into that conversation to get to these outcomes, okay? This is a model that talks about the ECHO biodevelopmental model of poverty and preterm birth. I have used this, and Shaw created this model. I have validated this model in some research that we did. And basically, what this looks at is the combination of poverty, and I'll use poverty as a marker of environmental stressors, right? Because whether it is an inner city or it is rural Montana, poverty equates to a limited ability to avoid environmental risks. Okay, if you are in a impoverished area and you have a heat wave, you are less likely to be able to avoid that heat and that risk. If you are in a inner city and they are doing big construction and there's lots of particulate matter and lots of smog, you are from a less affluent environment, you are less likely to have air conditioning or have the ability to keep your windows closed. Okay, so if we look at poverty as a marker of that, and then we add some toxic stress, which in this, when we use this, we talked about adverse childhood experiences, so things that add stress to an environment. Those things contribute to preterm birth, and then once the child is born early, continued exposure to toxic stress and poverty leads to some structural and functional brain differences, which can lead to impaired developmental outcome, which can lead to decreased educational attainment, which can lead to adult poverty, which can perpetuate the cycle. That's why when I talk about this, we talk about the effects of prematurity for this generation and beyond. Okay, because one of the #1 risk factors for having a preterm delivery is being born early yourself or having a prior preterm delivery. There's some research out there that actually says if your sibling delivered preterm, you are actually more likely to be preterm. But it's, and that's not quite, the numbers aren't quite as good for that, but it is a familial condition or an environmental exposure type of condition. So, doom and gloom, right? But where do we stand in the U.S. As a whole, going back to preterm birth rates? Really badly. Okay, this is the March of Dimes. The March of Dimes creates a map every year based on preterm birth rates and grades states in the U.S. based on the preterm birth rate goal of less than 8%. There is one state in the U.S. that hits this almost every year, and it's Vermont. The rest of us are not doing so good, okay? As a whole, the country, we rated D+. That would not get you out of a nursing class, folks. It might get you out of something else, but it's, nursing, where are my nurses? Can't get a D+ in a science, okay? You have to get a better grade than that. So, not to be political or anything, but I looked at the worst state and the best state, okay? So Mississippi has a preterm birth rate of 15%. It rates a solid F. And what I want you to see here is the difference between chronic health conditions that make you more likely to be born early. Smoking, 20% in Mississippi, 13% in Vermont. Hypertension, 26% in Mississippi, 13% in Vermont. Unhealthy weight, 17 compared to 8, okay? And diabetes, 32 to 22, okay? Now, not all of that is an environmental risk, but I would argue that if you're smoking and if you're living in an environment that might not be healthy for you to be outside exercising, that's going to contribute to your unhealthy weight. Extreme heat days in Mississippi, 49 days of extreme heat compared to 24. Okay. Vermont had better, Mississippi had better poor air quality days, so had less poor air quality days compared to Vermont. But I believe this is based on there was wildfire exposure that year that affected Vermont, Canadian wildfires. So that may have contributed to that. So that may have been a blip. But this is how the decisions we make through health policy, through education, through all of this contribute to long-term health. So if we can promote more sustainable, more environmentally friendly practices in our healthcare, in our environments, we affect not just one generation, but multiple generations. Not just one health condition, but lots of health conditions. And because prematurity is this multifactorial event, right? It's not just one thing that causes it. It really, in my mind, works well in an environmental health discussion because the environment really does play such a huge role. Now, again, don't get freaked out, okay? It's all about mitigating risk, right? So this is my nephew. Brian was born at 25 weeks. He spent a year in the ICU. He initially, his birth parents are from El Salvador. They had a language barrier. They had an economic barrier. They had some challenges in his early years. His father married my sister when he was about 2. Environment changed. They had a everyday translator. Their environment became different. Brian is an incredibly active 8th grader who made the soccer team and he plays goalie and really is just the neatest kid on the planet. He's an 8th grader, so they are what 8th graders are. But his health in general is pretty good, right? Does he have a little executive function issue? Sure, he has a real hard time figuring out how to make change. But we were able to change the environment and the resources that he had initially, and truly his outcomes changed. His respiratory conditions got better when people understood that his maintenance medications needed to be given every day, right? His father, who speaks, at the time spoke very limited English, would nod and say yes, right? When the pulmonologist would say, this is your maintenance medicine, take this every day. And he'd be back in the hospital because he thought you only give medicine when the baby is sick, right? Again, all of those pieces changed his outcome because we did better at our job. My sister had the ability to understand what the providers were saying to her, so she was able to say, oh no, the purple one, that's every day. Well, that understanding of directions changed his outcome, okay? Where they were living and how they were exposed to things changed their outcomes. So whenever we talk about preterm birth, I always talk about mitigating risk to maximize potential, right? So whether that's through providing adequate support services in school, whether that's reducing their environmental exposure, whether it's making sure that they understand their health directions, right? All of those things help to mitigate risk and maximize potential. So I did all that in about a half an hour because I would love to hear your questions. And basically anything prematurity is on the table. Yeah.
I'll start off.
All right.
That was great, Michelle. Thank you. Always a treat to hear you speak. I had a question about the relationship of preeclampsia with the prematurity. Does that include a significant portion of babies who were born premature because mothers had to be delivered in order to save their life?
Yes.
Okay.
Yeah.
So
You can't separate those numbers. The health risks, when you have women who so preeclampsia is a hypertensive disorder that puts the mother's life at risk. So we balance, the obstetricians and obstetric colleagues work very hard at keeping mom pregnant as long as she can be, but we get to a point where it's not safe. So we have to deliver them early. When you're looking at aggregate numbers and large numbers of preterm birth rates, you can't separate those out because they are a piece of prematurity. And cadmium risk is a big thing. We do see cadmium higher cadmium levels in women who have preeclampsia.
I'm curious about the international context for the preterm rates. I know in some cases we have better air quality than many other countries in the world. However, we have other things that would predispose these babies. How do we fit in terms
So our preterm birth rates are on par with other countries, with the caveat of saying that I would say we're on par with highly developed countries. We have a difficulty measuring preterm birth rates in countries where we are under-resourced because they don't have this conversation, right? They, infants are born early, there is not a resuscitation effort. So that changes our outcomes. Now, having said that, I have spent some time in the great state of Montana on an Indian reservation. And in walking through the hospital, when I was deciding whether it was some place to take students, appropriate place to take students, that 1870s incubator was what they had. Okay, it looks like a chicken coop. It is not what we would consider an incubator for an infant. I'm walking through the hallway and I went, what in the, love of the lamb is that? And why do you have it? And she said, well, that's the incubator we have. That's what we've got. And I said, well, what happens when you have a baby that's delivered early? And she said, Michelle, you are standing in a 32-bed Indian Health Service hospital. So most units at Bryn Mawr Hospital have more than 32 beds on them. So just for context, the whole hospital is the size of one unit, right? The intensive care unit at Children's Hospital of Philadelphia for infants has 100 beds in it, okay? Their hospital was 32 beds. So they had a woman in labor in one bed, dialysis in the next bed, a cattle ranching accident in the next bed, a drug overdose in the next bed, right? So no specialized NICU care, right? I said, well, what happens when you have a woman who delivers early? And she said, well, it depends on the time of year. There's snow on the ground 10 months of the year in Browning, Montana. If they can't fly you out to Kalispell or Great Falls because it's snowing, and the baby dies. If they can get you out, the baby might survive. So when we talk about low resource environments, there are low resource environments in the US as well as, other countries. So now the interesting thing about long-term outcomes in other countries than the US is that we use the Scandinavian cohort to Casey Crump from Mount Sinai, he's now at UT Knoxville, I believe, uses this Scandinavian data set because he can sit at a computer and data mine birth cohorts from Scandinavian countries and follow you from birth to death, right? So the all-cause mortality rates that we quote of 30 to 50% higher in people born early are based on Scandinavian data sets because we can't do that here in the US because I can't data mine that information. Why? Because we don't document gestational age and birth rate after you're about 4. So has anybody, you're all adults, has anybody in your adult life been asked if you were born early by a primary care provider? You weren't unless I taught them. You weren't, right? So we don't put that information in the hospital computer system for adults. We don't carry that information forward from traditional, from NICUs forward. Now, in the age of computers, maybe that will be different, right? And truly, if Epic starts to truly pull, as Epic becomes ubiquitous and every hospital uses Epic or Cerner, maybe we'll be able to do that for people born now. But if you were, I have a 24-year-old, a 22-year-old, and a 20-year-old. I guarantee that their health record does not say that one was born at 35 weeks and one was born at 37 weeks. Okay? Guarantee it doesn't happen. It's not there. What other questions?
Thank you for your talk, really eye-opening. So I was thinking that China might be an interesting case study for the impact of the environment on preterm birth because they've evolved very rapidly over the last 4 decades. So it's become a developing country. But on the other hand, it's also introduced a lot of environmental damage to the country. I just wonder if you have any comment on that or seen any data about it.
I don't know the Chinese data well, and they don't come to they're not a part of the Adult Preterm International Collaborative, so I don't know that data, but it would be an interesting, particularly from an environmental health standpoint, to look at that.
That's an interesting question. If you don't mind me piggybacking, what about India? Does India?
Oh, I was going to say India too.
Yeah. So there is some data out of India that I have seen, but I don't think it's long term. I think it's mostly preterm birth rates and initial outcomes, not longer term outcomes.
Thank you for the talk.
You're welcome.
I wanted at the beginning or the middle, you mentioned about the necessity for all women to be tested for lead exposure. Yeah. And if you want to have a family, so are there measures to mitigate lead
Yes.
exposure?
Yes. So part of what we do at the Atlantic Center for Children's Health and the Environment is we support children and reproductive health. So one of the things that we advocate for is identifying lead exposure and removing lead. Primary prevention for lead is to remove it. So houses born before 1968 have invariably will have lead paint in them. So you need to either do lead abatement or you make sure that that paint doesn't chip. Testing lead in the water, testing your water sources for lead exposure. Looking at things like paints, so inexpensive toys. So the toys that you find typically at a dollar store or a Dollar General likely have lead paint on them because they likely came from countries where they use lead paint. So families that are least capable of mitigating that risk are the ones that we inadvertently expose to that risk. So any type of, and you can live in a McMansion on, the main line, but have lead paint and not necessarily realize it.
That's interesting how it crosses through.
It does.
poverty
Lead is,
difference.
and that's why I push back with ACOG about using a risk-based screener for lead, because lead can be everywhere. So and it can be in the water. So we really need to look at where lead exposures are.
So if the body's not exposed anymore, it sort of purifies it itself?
So yeah, it does. And there are some things that you can work with to decrease lead absorption. So correcting nutritional deficiencies. So calcium, iron, and vitamin C will, if you have adequate levels of those, you will decrease lead absorption. So that's another piece that we can do is mitigate that risk with children by, so when we have a mom who calls and says, my child has an elevated lead level, we're trying to figure out where the exposure's from. Sometimes it's grandma's house, sometimes it's this, sometimes it's the child swallowed a piece of jewelry that had lead paint on it and they just keep reabsorbing it because it's stuck in their stomach. Sometimes we have to be a little bit Sherlock Holmesy trying to find where that lead exposure is, but the treatment is to reduce absorption. So removing the offending exposure and reduce absorption. So vitamin C, iron, calcium.
What other kinds of mitigation techniques or ideas would you suggest for, what would be, if you were going to say, I know you mentioned smoking.
If I were queen of the universe,
Right,
I
yeah.
love the queen of the universe question. Smoking, vaping, absolutely. Vaping is the same risk, right?
So is it nicotine?
So, and I'm not going to be able to do the science quite as well, but tobacco and cadmium go hand in hand, but the particulates and the exposures from the nicotine also affect lung health and development. Vape, the reality is we don't have any idea what is in that, and we've superheated it, and the toxic substances inside that superheated get inhaled into kids' lungs and do horrific damage to kids' lungs and God forbid that's a preterm who has bad lungs to start with, right? So tobacco and vaping would be, and lead, because I truly believe that they are targets we can manage, right? So I'm all about small successes. So if we could reduce tobacco exposure, if we could work towards reducing some environmental exposures, making better choices about how we do construction renovations in kids' schools, how we do renovations to emissions testing and things like that. So bringing down environmental exposures is huge. But tobacco and lead, I'll stand on that soapbox for now. What else? Anybody else? Yeah.
So in terms of the, also, I mean, you talked about extreme heat and some of these other factors like air pollution and things that are potentially part of climate change, are there sort of policy solutions that you recommend?
So anything that's going to bring down our global heat and our global temperature, I'm all for. Bringing down those duration of days where we have extremely high heat, that's going to improve child health. It's going to reduce preterm birth rates. So supporting those policies and those changes are good. Being more aware about preterm birth as a long-term health risk. So when I speak to a different room of people, so at the CHOP Chronic Lung Disease Conference over spring break, I really did mess with the minds and hearts of a whole bunch of neonatologists and pulmonologists, because they were taught at the same time, most of them are, I'm a little over 50. I went to nurse practitioner school in the late 90s. The mantra of healthcare at the time was kids born preterm catch up by the time they're 2. The ones that don't catch up are obvious, and everybody else you don't have to worry about. Okay? So you extrapolate that to a lung disease conference where people talk about, well, the preterm lungs, once they're off oxygen and they've had a couple of good years, they're fine. They're going to be fine. There's no long-term health risks. Well, then I stand up and say, here's the long-term health risks, and highlight that, hypertension is higher, heart disease, diabetes, all of these long-term health risks that are common to the whole population, but happen more often in someone born early. That's the other big soapbox I stand on, is that preterm birth should be, gestational age and birth weight should be documented, and should be diagnosis that follows you throughout your lifetime. Just like we ask if you have a family history of heart disease, or if you have a family history of diabetes, we should be asking if you were born early or not, because it changes how we decide how we treat you. I would advocate that if I knew that a 16-year-old female came in with borderline hypertension, maybe a little bit overweight, right now, my partner or my colleagues at the clinic might say, you probably need to watch your salt intake. Are you stressed out? Let's try and reduce your stress. Maybe go to the gym more often. We do these, sort of platitudes, health style interventions. But if I also knew that person was born at 28 weeks, I'd say, your blood pressure's up, and you've got this risk factor and this risk factor. So instead of waiting 6 months to check your blood pressure again, you're going to come back next month, and we're going to check your blood pressure. And if it's still up, we're probably going to talk about starting you on some blood pressure medications, because I don't want you to have a stroke, right? So adding that piece of health history changes how we potentially affect, treat patients. So yeah, that's my other soapbox. That's my other queen of the universe.
Thank you. On the intergenerational question,
Yeah.
You mentioned this Swedish and
Yeah.
data on this. What percentage of mothers or preterm births who become mothers then have preterm births?
It's something like, if the average female has a 4% risk of delivering early, if you add prior preterm birth or family history of preterm birth, you're increasing that risk to 20%, to 25%. If If you add preeclampsia to the mix, you're now at 48%. So, you know, and whether that preterm delivery happened because that first delivery happened due to preeclampsia, that 48% might actually be higher. So you can significantly contribute in that intergenerational factor. And, you know, environmental exposures cause epigenetic changes. So those changes then take multiple generations to wash out. So, you know, life changes. It's the, you know, job security for me. But that's not a great way to look at it.
Do you know of any methods that we can implement after birth that can affect, like help prevent the issues that happen later in life?
So healthy lifestyles, providing adequate support for neurodevelopmental outcomes. So, you know, making sure that those kids get the support services they need early, maintaining good lung hygiene. So, you know, keeping them away from tobacco exposure, keeping them away from pollution as much as you can. Perhaps, you know, being able to eliminate their exposure to the sequela of extreme heat, right? So all of those healthy things will help them, right? We just need to be better at having the ability to do it. What else? Any other questions? I'm in Driscoll Hall, you know, Michelle.Kelly. Ask me questions, reach out. This is something I love to talk about. So if there's, you know, a burning need or a question, please reach out.
Thank you, Michelle.
Thank you.
Thank you, Kelly. The purpose of the talks obviously is to give a broad overview of all of the wonderful scholarships being done at Villanova in the area of climate justice and sustainability. Perfect example. Who knew, unless you really think about it. Our next talk is going to be Thinking Trash in Latin American Art. This is going to be presented by Professor Agnese Cordebo. She was sitting in the front there, Professor of Spanish, on Tuesday, April 15th. Hope to see you there. Thank you. Last week.
We could do it in front of the speakers. Yeah. I'm just like, does that count? Let's just take it right here, I think. Should I take a 0.5? Yeah. I'm really scared.
Wait, I also.
Yeah.
Oh my god.
Wait, can you even tell that we're in here? Like, no, but also last week
no,
it would be
no,
real.
yeah.
It was like so big. Like it's right. Like we're about to just 10 minutes going. Wait.
Do like
Should we?
I feel like that'd be like right. So like literally
That makes good sense.
that's you know, it's a conversation for everybody.
Yeah, I'll just stand here.
It's kind of evolved into this bizarre little world that I'm living in. I started, you know, my dissertation was looking at 8 to 12-year-olds, and then as
Okay. This is like,
I'll try and get it
like
done.
Gone back and looked at the later outcomes and later outcomes. And work with a
Yeah.
in the UK who is adult preterm birth survivor.
Wait, what's your guys' names? You're
And
And wait, are you you're in my ordo lab? No, you're not in ordo. Oh, you're fine. You're my
Shock head.
maybe like
And she is someone who did not have.
probably.
are you friends?
Not
I don't know what it
Arushi.
might actually. It's probably not you. I might be wrong. Are you friends with the kid?
I definitely like, you know, like unknown, like yeah, No, honestly, yeah, maybe we did.
Familiar, but I haven't seen you.
Oh, and then maybe I'll need. Thanks for the invitation. I'll table in front for the sign.
Nice to meet you.
We'll
Yeah.
see.
What, are you gonna project the last one or?
So they're gonna have the actual. But I think all the way.
Like, are you in our class?
Yeah. Oh, yeah. Section one. Yeah. And then the
Section one. Oh, we're section one. We're just 12:50.
Oh, yeah. I am in 12:15.
Okay.
I should be. Am I? No, 11:45. Okay. No. I was confused.
Okay, it's nice to meet you.
Yeah. I'm getting lunch early. Gotta come.
Maybe.
I was never.
I think so. They have this warm air alert curve.
Sean is 11. I'm over at Disney World. We'll be in touch later in the week.
Yeah.
We should also, we need to sit down and have this, learn about.
I knew
Yeah.
it. It was just like,
We should talk to you before.
it's not in their
Yeah,
heart.
and you see that we're gonna be
Yeah.
meeting.
Yeah.
It's,
Okay. See you later.
Oh, yeah, so, no, yeah, you need to tell, no, go to, go to the box.
Maybe they disrupted, or maybe somebody prematurely cut the link so that you may not see what schools are doing this, so that it's
We
not
need to
like,
find out what the other
but still,
amount is.
actually,
PubMed was down for an entire day. I was doing work on another project. It was closed, it was shut
when
down.
I was trying to update my current pending through NSF for something else, and it was like ridiculously slow, and then I was like timing out.
Yes, no, it was completely down the one day. It was like, and then afterwards, what was the second thing was, there was like a hole that I knew I right before, right? Wasn't it, I lost it, I didn't remember, I filed it, or whatever. So I put through all this.
tell you.
Okay,
It
you can
wasn't
send me
coming
an email.
All
Here's
right.
what each one of them is, and I'll say where to go.
Yes, they scrubbed that out of it. It was all about
See you next year.
mortality.
We do.
Review, data review from
think the
36
main
states,
thing
maternal mortality review. And we were talking.
So I'm gonna put
Okay.
wheelchairs on.
Yeah, I guess there's some follow up.
I'm gonna make sure I have at least 60 to 70.
If that's why we can't find it now.
Right, and yes. And maybe even just following up from it.
I'll worry about the studies.
All of our publications are last behind, and we trust that like our
I know.
scholar and
I know, so it's a good thing I had a backdoor way to get to that,
yeah.
and I got it, and but it was, I couldn't get it
Print out all
from
my
PubMed.
favorites.
It was like,
I
I know.
Want to come up with an agenda.
And then the rest of the team.
Yeah.
Do you want me to wait to send a reminder?
No, it's the wrong way.
Oh, I didn't tell you, my grandson was accepted to the, exact title of his major at Temple, the College of Engineering at Temple. I'm so excited for
Right,
him.
sounds good.
Basically, it's computer
Thanks for
science.
coming.
Great. Yeah, here we go. Engineering technology is what they call it.
Is he already there, or?
No, he's a senior in high school, but he got accepted to the fall, and that's what's hoping.
It's gonna be very hard to like get this stuff to like not move, but you know. Also, I noticed someone moved the popular region when I moved in. Oh, you did? Okay. Sorry, because no, it's like literally they were sitting up there and it was like, oh, view, so I can move it back. I can move it back. Okay, I didn't know if they did it. Literally in a really awkward position for the talk. It looked intentional, so I was like, they might have. I was like, they might have done it. So like, I had to check with them before I moved it back, and then I relayed it, and it was not looking good. It was like dead center of like the eye line. Yeah, they were talking. No, that's much better. That's much better. So I ended up issuing. Yeah. But yeah. So.
I don't know if I successfully turned the projector.
Oh, yeah,
on.
that's okay.
It's
We'll
still
check it.
blinking.
Okay, we can check it. No worries.
Right.
Yeah, it was weird. It did that blinky thing. It's never done that before.
Well, it was not blinking
here and